NCLEX case study. The first two, 3 lines should give you a clue. If you can't find what they're talking about, keep on going, but go for the buzzword. Make sure every sentence is supporting something in the first 3 sentences, right? 10-year-old is in the outpatient pediatric clinic, okay, for routine exam evaluation. So there's nothing benign there, nothing big there. Just went to the hospital. Parents report what? He spaces out during classes. Buzzword. That is the chief complaint. So I'm going to underline the keywords. It's a 10-year-old. That is a keyword. In classes, it spaces out during classes. And then after that, there's a slight shivers of the lip. So his lip will rumble a little bit. The episodes happen several times a day. That's key, right? Multiple times a day. Each lasting what? A few seconds. That's all. Per parent, the teacher describe it as what? Buzzword, daydreaming. You see, those are the single words is connecting. They're talking about spacing out, which occur as daydreaming. The spacing out is occurring in 1 second, very few seconds. The spacing out is occurring multiple times a day. So follow the pattern, but it's a storytelling, right? But there is no what. I say when you do NCLEX case study and you see the word no, step back, underline it. It's the key information for you to use to make a diagnosis. There is no what? Confusion after each episode. Occasionally, he will not know what has occurred. So he loses it, he doesn't remember what happened a little bit occasionally, but not all the time. So most of the time, you remember. There is no what? Once again, the word no. It's not falling down. There is no muscle contraction. There is no loss of bladder and bowel. Those are your key. Have you figured out what this patient is suffering from? 10-year-old, spacing out in class, lasting few seconds, look like he's daydreaming. There's no confusion. It doesn't fall down. Muscle does not contract. No bladder problem, no bowel problem. And by what? It might and basically shivers a little bit. His vitals is all normal. He's alert. His physical exams is completely normal, right? If you look at it, neuro is 5 out of 5. His sensation is fine. And they give you EEG. They did the EEG. There's a 3 airs of spikes, right? And wave complexes. That is what? Per second. As you can see, this is normal. If they give it to you, this is what they will give it to you. This is all normal. But as you get here, from here to here is 1 second. And there's 3 spikes. 1, 2, 3, 1, 2, 3, 1, 2, 3. Those are typical, is a diagnosis for this condition. What do you think this patient is suffering from? You should be able to make a diagnosis. The word EEG should give you an idea, right? And try to helping you. NCLEX will make it a little bit difficult, but look at it carefully. And so this is the condition the individual is suffering from. You have to put it together, and then you can make a diagnosis. So what do you think is different from? Tonic seizure? Is it conversion disorder? Is it absent seizure? Is it dissociative disorder? When you see these questions like that, answer choice, go, and they said, okay, I don't know what it is. I've figured out what it is. Look at the answer choice and then try to eliminate them. And he said, what is that? What is dissociative disorder? Dissociative disorder is the individual attaining different identity, right? Identity, like today is Mary, tomorrow is um, Joseph, right? It take 2 identity and they flip back and forth because of stress. Something happened and they assume different identity. And they try because they don't want to deal with that issue that happened to John or Joseph, and they move from each other. This does not tell me that. Tonic-clonic seizure. There's a reason why it's not A, right? Why is not A? Who knows why it's not tonic seizure? No muscle contraction. There's no bladder problem and there's no bowel problem. This is why they are there. There is none of this is there to make this patient have a tonic-clonic seizure. There is no muscle contraction completely, right? And of course, conversion disorder means you have uh, symptoms that cannot be explained with a neurological finding. You think you have stroke, but then when I examine you, I don't see evidence of stroke. That's conversion uh, um, disorder. You think you have a heart attack, but your EKG is all normal, right? So those are the things you can see. And this is a classic symptoms of absent seizure. A young patient, buzzword, in class, daydreaming, staring, lasting for a short time, and an EEG, there's a three spikes. Know them. Those are the diagnosis of absent seizure. You see, buzzwords. There's NCLEX will give you that. If they don't give you, then they're not being fair. They have to give you enough information to be able to make a diagnosis. Diagnoses are not made in space. It's made by patient symptoms. And so they will give you enough information, but you have to go and weed them out, pick them out. I do not spread them, I put them together. But when you're reading it, make sure everything fits the first two, three lines and it makes sense to you, right? So this is absent seizure. It's a content you have to know about it, right? So the same thing, that's the patient, 10-year-old, episodes of spacing out, daydreaming, no confusion, um, no fall, no bladder problem, neurologically intact, and this is what the EEG will show. Now, what prescription the nurse should anticipate for the client? I just added this so that you know the pharmacology. If they give you this question, you have to manage this patient. The number one thing they may ask you is what medication you give them. It's a seizure, right? You give them anti-epileptic, but you have to know which one do you think the patient will get. Is it carbamazepine? Is it ethambutol? Is it etoposide or phenytoin? So phenytoin, etoposide, or ethambutol or carbamazepine. What do you think? There is three seizure medication there. Test taking strategy. You should know there is three seizure medication there, right? So why do I want to give you three anti-epileptic? Carbamazepine, etoposide, and then phenytoin. You know, ethambutol is used for TB, so this is out. So why do you think I give you carbamazepine, etoposide, and a phenytoin? There's a reason why I give you that, right? I give you those information because I want you to know that not every anti-epileptic can be used for this condition. Not every anti-epileptic can be used for this condition. There are specific ones that are designed to be used for this, and not all of them can be used for that. So pay attention carefully, right? Carbamazepine is not used for that. So A is wrong. It will worsen the condition. So you always worsen the condition. Phenytoin is also the bad anti-epileptic for absent seizure. The common one, the first line is etoposide. The second one is valproic acid. So if they don't give it to you, or lamotrigine, lamotrigine and valproic acid or etoposide is what we use for absent seizure. This is the pharmacology related to these conditions. So make the diagnosis and we manage it. I'm not going to give you 6 case study, but those are the things. Of course, if they give you, you have to know how to take care of this patient if they are in a hospital to prevent seizures and all the things you want to do. Anybody had any question, you can type it if you do. Next case. Next case is a full of trap. I want you to read it carefully. Don't jump the gun. Pay attention to the keywords and put it together. It's a common NCLEX question. I've had somebody take a test. They said everything looked like this. Everything looked like this. I can't figure it out. 30-year-old college student present to the outpatient mental health clinic with 3 months buzzword. 3 months is buzzword. History of overwhelmed by feeling of what? Sadness, tearfulness, depression following breakup with the boyfriend of 2 years. That is your diagnosis right there. Diagnosis right there. 3 month history of being overwhelmed by feeling of sadness, tearfulness, and depression following a breakup with a boyfriend of 2 years. So they broke up. She reported intense fear, bad word, and concern that she may never be in a relationship again or fulfill her dreams of having a baby. Since the breakup, she has avoided family and friends and no more the highest performer at workplace. So she's losing the ability to do well at workplace. Deny any suicidal ideation, no hopelessness. Still enjoy usual 3 mile run every day. I've given you enough information to make diagnosis from this. What do you think is wrong with this patient? There's a bunch of buzzwords. Pay attention to the fact that they broke up with the boyfriend or his spouse, right? Or not the spouse, the boyfriend. Vitals normal, and you examine it's alert, oriented. The mood is sad. Affect is appropriate. There's no hallucination. Good eye contact, no psychomotor agitation. The patient is very calm. Can you figure out what is wrong with this patient? 3 months old, they broke up. All of a sudden, having all this feeling of sadness, tearfulness, depression, feel like they've broken up, and then anxiety related to the fear of that she's not going to have a baby, not have anybody to be with her anymore. Now she's not doing well at work. Think about it. Think about it. Think about it. Think about it. Think about what is going on here. A straightforward content and be able to figure out what do you think this patient have? Major depression, bipolar disorder, adjustment disorder, generalized anxiety disorder. Figure it out. Figure it out yourself. Look at it. Is this bipolar? Is this adjustment disorder? Is this depression? Think about it. Generalized anxiety disorder. If you don't know, I want you to pay attention to the keywords and you'll be able to figure it out, right? 30-year-old college student for 3 months, broke up with a boyfriend, now with intense fear, concerned about not having a relationship anymore, feel sad, losing functionality at workplace, still run 3 months, has no hopelessness, right? No suicide. The mood is sad, but the affect is fine. No hallucination, good eye contact. There's no psychomotor agitation. What do you think is wrong with this patient? Think about depression. They will not use the word depressed. The good examiner will not use the word depressed. They will give you signs and symptoms related to that, like that. CGCAP, right? Some sleeping issue, like energy issue, right? Interest, you feel guilt, energy, concentration, appetite, and psychomotor agitation, and maybe some suicide. They will, even if they want to use the word depressed, they will use sad, right? So NCLEX will not do that. They're not supposed to do that. We can, but you see, I give you depression, and I told you the patient is also anxious, concerned about never going to have a relationship. So there is acute depressive symptoms. There's acute what? Anxiety issue about not having relationship anymore. And when this happened? After they broke up. And when did it occur? 3 months. If today is your first time listening to Adapt NCLEX, I want you to pay attention. This is the key. If something happened to somebody, they give you a question, something happened to them, and all of a sudden, it's been 3 months, they're having depressive symptoms, they having anxiety issue, and it affecting their work function, but they don't have hopelessness. They don't have their interest of the activity of daily living is going on. They're doing the things they love. It's not depression. It's not anxiety. It's an adjustment disorder. There's an acute stress disorder that is putting this patient in this condition. So don't fall for it. It's not depression. It's not anxiety. It's called what we call adjustment disorder. This patient is adjusting to the situation. It cannot be a bipolar. After 3 months, and if it doesn't occur here, then you can classify it some mini depression. But remember, there's always a stress that happens, and all of a sudden they're having these symptoms. This is a key to make a diagnosis of adjustment disorder. So it's not depression, it's not bipolar. There's no signs and symptoms of mania, right? There's no generalized anxiety. The generalized anxiety, you don't have specific anxiety about anything. She has specific anxiety about worrying about not having any relationship anymore, and she's worried about it. So this is classic examples of adjustment disorder. I'm using these examples so that you guys can be comfortable when you're reading questions. Next one, based on the client data, which condition the nurse should suspect the client is most likely experiencing? This is a question. This is a straightforward. You should be able to make diagnosis easily. 70-year-old, present to the emergency room. Keyword, because the spouse noticed what? The client suddenly started slurring the speech. The spouse report difficulty moving the left hand and leg. That should give you away. Slash speech, left hand and leg is affected. Vitals, slightly hypertensive. Is alert. There's asymmetrical smile. When you smile, it's asymmetrical. Buzzword. There's a left-sided facial droop. Buzzword. People are equal reactive to light, right? And accommodation. Lungs is fine. S1, S2 present. There's no bruit, right? But what is the problem? The left arm, when you straighten it, there's left arm drift. If you stretch the arm and then facing up, its palm face down. That is what we call pronatal drift. You push it, putting your palm down when your eyes are closed. It's supposed to remain where it is. If you close your eyes and you stretch your hand and you keep your palm up, everybody will keep their hand where it is. If you have something going on, your hand would drift. We call it pronatal drift. There's a motor deficit on the left side, and it's on lisinopril and metformin. What do you think is going on? What do you think is going on? Why is it not Bell palsy? It's straightforward. Think about it. It cannot be Bell palsy. Bell palsy should have what? Why is it not Bell palsy? Why is it not hypoglycemia? Why is it not stroke? Is stroke or why not? Why is not transient ischemic attack? This, they will describe it as curtain falling on their eyes, like they're getting blind. The case does not describe that. Hypoglycemia, yeah, it can mimic that, but I have to tell you, patient is showing some other symptoms, diaphoretic, palpitation. All these things is a buzzword you should be looking for, right? It cannot be Bell palsy because one, I'll give you something about your symptoms. Second, they should not have weakness anywhere, body weakness. The body does not, the only thing Bell palsy affect is your face. That's all. There shouldn't be anything related to your body. So those are the key words you look for when you're reading these kind of questions so that you don't fall for them. I've given you differential diagnosis. I told you, you see, one word I can use to distinguish between them. If the rest of the body does not have any weakness and your face is drooling and you have acute slurred speech, it has to be Bell palsy. It can't be stroke. Hypoglycemia, I have to give you sympathetic signs of activation, right? Tachycardia, diaphoresis, right? Confusion. I never give you any of them. And ischemic stroke, I will tell you, it happened all of a sudden and the vision came back. The case never said that. So don't pick an answer choice that is unrelated. There's nothing in the case that offer you that. Stick with the case and don't bring any information into it. So this is a stroke. So what do you want to do? Which action should the nurse take? Now, this is the test-taking strategy content. You cannot just memorize this information. You have to understand the situation. What would you do with this patient? You would think he has stroke with slur of speech and all those things. You give them a TPA. You get a CT scan. You determine when the stroke happened, or you evaluate the client's airway. What do you think? This is what I call buzzword. Buzzword, right? This is what I call buzzword. And using be sharp. You have to be sharp. Don't pick any answer choice. I want you to be sharp. If you have 1 second and you have to do one thing, which of this would you want to do? They all look nice. They all look attractive, but don't let the attractiveness make you pick them. Let them go and sit back and ask yourself, I have 1 second. What would I do? Which of this will benefit the patient more? That is what I mean by be sharp. Don't memorize prioritization. Just think about it and said, if I have 1 second and I have to choose one of this, something that will be more beneficial for the patient, what would I do? And use the content to pick the answer. I know I have to give them TPA, but guess what? You can't give them a TPA if you don't know that you got there's blood in their brain. So you got to get a CT scan before you get a TPA. Test taking strategy. Don't pick A because you got to do B before you do A. Now, when they come in, I need to know when the stroke happened before I can give them what? TPA. You see what I'm doing? You see how the answers are connected? But if they don't have airway, I don't even have time to get a CT scan. If your airway is not there, well, the CT scan become moot. And if I don't get in CT scan, I will not know whether I need to give you TPA. Secondly, I will not know what time your stroke happened. All the answers are indicated. So number 4 is the most prioritized information. Okay, guys, I know you guys get it. And the last one, this one, it may be hard, but it's not. It's not, but look at it carefully. To the emergency department with speech impairment. The SPAL report these new symptoms after a left-sided stroke. Don't fall for it. Keyword, this happened after what? Left-sided stroke. Case study are your friend. They will give it to you in the case, in the exams. Don't freak out. Don't worry. I want you to sit back and relax. And just basically, just whatever you want to do, just relax. Put your pen down and say, look, this is my case. All the answers are in the case. And just read it carefully. Try to look for the buzzword. They're going to distract you. Take the keyword, connect them, and they say, oh, I know this problem. The rest of the answers are easy. I told you, 70-year-old, he came into the emergency room because he's having what? Speech problem. I did not say he was slurring speech. But when did I say? I connected the first one. I said, this happened after he had stroke 3 weeks ago. So he's recovering from stroke, right? And he has history of hypertension, no weakness. I told you, no more new weakness. He already had a right-sided weakness from his stroke 3 weeks ago, but now he can't talk. He has hypertension, right? He's alert oriented. And then the rest of the physical exams I'm trying to show you something. He has word finding difficulty. Do you know any stroke symptoms that will give you word finding difficulty? Non-fluent speech. He pronounces word incorrectly, but his comprehension is intact. He cannot express himself, right? He has good insight of the problem. That is the key. And then he's depressed because he has good insight. It does not confabulate. What did I tell you? No is your friend. When I put no there, I know is going to help you. No confabulation, right? That's the key word. No confabulation. And he comprehend the information. He has weakness because he just had stroke before. If you know, I've like really guided you what you need to pay attention to. Somebody 70-year-old is having a problem expressing themselves. Their speech is not fluent. They cannot pronounce the word correctly. What do you think is going on? They have insight of their problem. What do you think? If you don't know the content, it's okay. I've given you the content. If they give you a selector apply, they'll put all the things I've put over there in the selector apply and figure out, is he Wernicke aphasia? Is he expressive aphasia? Is he acute ischemic stroke? And is Alzheimer's disease? This is the key. He came in because of speech impairment. And so your answer choice has to address that. Don't pick any answer that does not address speech impairment. It cannot be stroke. Don't pick C because he already had stroke. The signs and symptoms you see is already related to stroke is already there. Right-sided stroke. And I told you there's no new weakness. So he's not suffering from anything anymore. This is what we call Broca aphasia. If you don't know it, I think I have a free video on YouTube. You can watch it. I talk about all these things, stroke, or it's part of the membership. But if you don't know, I give this to you free, right? Write this, rat and beef. Wernicke aphasia, they have receptive aphasia. That means they cannot receive. Comprehension is affected. You see, comprehension, receptive aphasia, and is found in the temporal lobe, right? Temporal lobe. If they draw a diagram and say indicate, is at the back. Broca aphasia is an expressive. They cannot talk about it, and is found in the frontal lobe. And that's what this case is about. So this is a Broca expressive aphasia. The patient is aware of their symptoms and therefore they get depressed. They can't express themselves and they will use yes or no. Unlike Wernicke, they are like alcoholic, they're drunk. They will make words, confabulation. If you look at this case, I told you, I'm not making words, right? They have confabulation because they don't understand what you're saying. Wernicke people, they basically they can't hear you. They don't understand. They cannot receive receptive aphasia. So what you're saying, they don't understand. In order to show you that they're listening, they will make things up. They'll start making words that it doesn't make sense. Confabulation. And they don't have insight of their problem. So they just talk and talk and talk and make no sense. This is Adapt and Class. Thank you for joining us. If you want more, you can just subscribe to YouTube and or join our membership or the on demand or just join some of our crash course. Take care of yourself and good luck. I hope you learned something. Best of luck. Bye.